everybody for joining us today, and welcome to Clear Week 2023. This week we're showcasing the work of frontline staff who've been delivering innovation projects within their clinical services to drive change. And welcome to day 3. This is the first session of the day entitled Tackling the Backlog in Elective Care 2 Clear Case Studies. This session will explore how Clear has supported 2 NHS trusts, the Queen Elizabeth Hospital King's Lynn NHS Foundation Trust and East Sussex Healthcare NHS Foundation Trust with their elective recovery plans. We're hearing from senior leaders from both organisations on their challenges and progress. Please note that the webinar will be recorded so we can share it with others who aren't at this time. Please also don't forget to join us on Twitter and follow our tweets and of course share your own thoughts. The session or the handle for this week is Clear Week. And our the hashtag for this week is Clear Week, and our handle is @Clear4Care. Our speakers today are Dr. Ken Ting, Clear Project Clinical Lead and Anaesthetist at London Northwest Healthcare University NHS Trust, Dr. Alistair Steele, Clinical Director at the Queen Elizabeth Hospital NHS Foundation Trust, and Joanne Dale, Deputy Chief Operating Officer at East Sussex Healthcare NHS Trust. I hope you enjoy this session, and I'll hand over to you now, Ken.
Brilliant. Thank you very much, Nimisha. So what I thought we could do as a very brief introduction is thank you very much to everyone for joining us on the call today. What we'll do to start off, if possible, is, Nimisha, would you mind moving to the next slide? Actually, before we do that, Alistair, Joe, do you want to introduce yourself very briefly as part of this?
Thank you. So my name is Joanne Dale. I've joined the Trust, East Sussex Healthcare Trust, only in January, so quite new to the organisation. So I'm there supporting elective recovery, and I'm also picking up, as you've heard, the role of Deputy Chief Operating Officer. So this clearly picks up all the planned care agenda for the organisation, so the work around the clear recommendations and the information provided through their work is very much integral to some of the recovery work that we're doing there. So nice to meet everybody this morning.
Thank you, Joe. And Alistair.
Good morning, Alistair. I'm an anaesthetist at King's Lynn and CD and been with the Trust on and off for 20 plus years. Thank you.
Thank you very much, both. Brilliant. So, thank you very much, Simon. She predicted it if I could get there. So what I thought we could do, hopefully in the next sort of half an hour or so, is give a bit of an overview as to where we are with elective recovery, the national context, the challenges that we face in that area. And then we can talk a little bit more about the case studies and the 2 specific cases that we've got here, what Clear's done in each of those areas with the people on site, and perhaps hopefully have a bit of an opportunity to just discuss and sort of questions from the floor. With that, we'll without any further ado, I thought I'd start off very quickly with the sort of high-level reflection of what we have. I suspect everyone's been aware that here in the UK, we've been seeing progressive number of people waiting longer and longer on operating lists. And at the last tally, we have about 7 million people waiting for treatment in the NHS. And we can see from the graph on the left-hand side, actually, this is probably not a new problem and has been brewing from a very long time ago. But the pandemic really sort of triggered a cascade of events, supercharged these waiters. And what we have now is just this cohort of patients that are currently waiting nationally for some form of operations or treatment in the NHS. Now, thankfully, the NHS has recognized a lot of this. And last year in February, a plan was published to suggest how they would like to approach these key challenges. To that approach, a series of targets have been defined. As of last June, the idea was to eliminate anyone waiting more than 2 years for a treatment. In about a week's time, they would like to eliminate anyone waiting longer than 18 weeks. And within 2 years from now, the idea is to eliminate anyone waiting more than a year. This is amongst a whole series of other targets that have been set out, but those are the key 3 ones which has been driving a lot of the changes that we've seen throughout the NHS. Coming out of those few targets, they've suggested a series of new plans, and this includes the 4 key priorities of how they would like to address these challenges. Now, the first part was all about increasing capacity. How do we improve the way we work within the NHS, either by just quantitatively increasing the number of staff, recruiting more, building up areas so that we can actually get through the operations or the treatments and get them delivered better? How do we use technology better so we can support the NHS systems? And then the second part within that is how do we prioritize work and so allow us to address everyone in an equitable manner, regardless of, again, context, deprivation, race, so that everyone who needs it are actually receiving the care they need based on their clinical need. The third part has been a drive to understand and try to deliver diagnostic and surgical hubs so that actually work which can be performed at scale are sort of taken opportunity of. And then the last part, which is amongst my favorite, is really trying to empower patients and get patients to be part of the conversation in their care. So getting them in at a very start, understanding their journey, getting them prepared and subsequently optimized for the actual operation itself. Now, falling out of these 4 key priorities have been a recognition at a national level and at a local level. And what we have here from the 2 case studies was, one, at a system level, a recognition of the local challenges, and actually wanting to understand how we could face this. And we're going to move to QEH in a second, where we're going to talk about this. And then the second one, was ESHT, which has been driven from a national level, which is to say, how do we improve our capacity alongside the use of digital software rollout? And we'll talk about that separately as well. So actually, thanks, Suman. If I pass over to Alistair to give a bit of a context on QEH, please. And Suman, if you want to move to the next slide, please. Thank you.
Thank you, Ken. Yeah, the Queen Elizabeth in Kings Lynn, based in Norfolk. We're a rural hospital. We have about 500 beds, so on the smaller side of hospitals and part of the Norfolk integrated care system. We have about 18,000 operations a year, of which 12,000 of our procedures are done as ambulatory day case procedures and 6,000 inpatients. And just for context, about 2,500 deliveries. So reasonable activity, and by model hospital standards, very much kind of not an outlier, middle of the road, but that's not good enough. We want to be more than just middle of the road. We want to be as good as we can be, and that's why having Ken and the team come in has been really helpful over the last year to identify areas in which we can improve. Now, we've been quite used as a hospital, as I'm sure many hospitals are, having external consultancies come on in, and over the years we've had many, and they tend to all say the same thing, like start on time, reduce your late starts, and you'll be fine. And of course that doesn't work. We know that doesn't work, but the clear approach was refreshingly different. And what we've spent, I guess, a year now, Ken, looking at all of this data to really understand the data, the sort of profound knowledge that goes with trying to improve a system that was lacking in previous reviews of our work. And of course, a lot of the problems were identified changes around the COVID time. So we found that although we were doing okay before COVID, of course, a big dip in activity with COVID. And if you look at our data post-COVID, we're not quite as productive if you just look at the raw numbers as we were beforehand. And Clear has been able to help us identify some of the reasons for that. And in Kings Lynn's example, some of the reasons are, for example, we've moved a lot of our activity out into outpatient settings. We, over COVID, bought out our private hospital to expand our area, our footprint for undertaking elective work. But the clear data analysis has been able to show that the impact of opening up a new area in the hospital, which was actually quite remote from our main operating theatres. So this, what seemed like a good idea and probably was a good idea in many respects, actually impacted on our ability to, for example, send for patients, added on 20 minutes to our sending time for patients, and that had a real knock-on effect in our operating theatres. We've also probably had sicker patients now than we had 3 years ago due to the wait. That's perhaps slightly more controversial. But we've had the clear data has enabled us to separate into themes the areas which we can now focus on. So we have a theatre improvement group within King's Lynn, and we're using the clear outputs as our themes for focusing on. So we're not focused on reducing late starts, but we're focused on things like getting the estates right so that the patient's journey is as smooth as possible, where those are the sort of areas that we've really benefited from over the last 6 months, year.
Thanks, Alistair. That was an impressively succinct and actually detailed explanation of it. You might have done my work for me. But what I thought we could do as well actually is, if I take over the screen for a quick second, Suman, is I'll just reflect a bit on some of the things that Alistair discussed, and evidently emerging from site. And what we've always found on site is the people who's been on the shop floor, who understand the patient journey and the reality of things, tend to have a fairly good understanding of things even prior to any one of us doing any bits. So what we've done at Clear and the methodology that we've employed at Clear has allowed us to do a series of different things. So above everything else that Alistair described, we've spoken to a whole series of people inside. But one of the other things that we've actually managed to do was obtain over 100,000 operative records at site and understand the reality that was happening in here. It's probably worth noting that QEH is probably one of the most data immature trusts in the country, have gone on a journey with us to obtain this information. This is where we are at the moment, where on this graph, on the x-axis is time, and then on the y-axis is the number of operations performed weekly. And what we have here, as you can see, is the weekly operations that's gone ever since 2016, and probably no prizes here for the big drops in March 2020, when this little thing called COVID kicked in, and the second wave that occurred, and that then went on further from that. Now, what was really interesting is, if you look at it from a wholesale perspective, it looks like the numbers have dropped quite significantly. But part of the conversations here was then to have these conversations back with people on site to say, why has this occurred? And now if you look at this detail and a bit more information, what we see here is actually the biggest drop in numbers. Even though in main theatres, what we can see is actually the people operating in main theatres have been operating as hard as they were, and they've been doing as much as they can still. But what we do have here in day surgery is actually quite a marked drop, and it's trying to understand what's happened here, because actually this doesn't reflect the reality of what they could feel on the ground. Now, because of the way we've done our work, what we could now do is to say, right, let's try to understand what's actually occurred in this area, and let's break it down by the location and the speciality. And what I'm doing here is now just flicking through every single speciality that's been operated on. And what you can see is, in terms of general surgery, they've operated on between 10 to 20 operations per week, and the gaps when theatre were closed, so there were no operations then. But what you have here is this really quite marked drop in a single speciality, where you can say, okay, what's happened here? Because this is probably going to explain the biggest shortfall in our numbers. And speaking to the people on site, you start to understand that actually the reality was that work was still being performed, but performed in different areas of the hospital, which weren't being logged on the same system that other operations were being had. So this was a recognition that actually one of the key challenges here was, how do we recognize that work is still being done, but where are they being done at, and how do we take into account of the information here? Now, one of the very interesting things, beyond all the other interesting things that we did here, was to look at trauma and orthopedics. Now, as Alistair described, the population served here can be quite deprived. And actually, at a local site, they were seeing more sort of neck of femur fractures and unfortunately frail populations falling down in various guises. What we could now look is to understand a little bit further on how they operated, and what we could see is actually on our x-axis is time, on our y-axis is the utilization of the trauma list. Now, what's quite interesting is they run the operating list in two manners. One, as a full day list on a Monday and a Friday, and on a half day during the middle of the week. And what you could see in blue are your full day lists, and in your half day list in orange, where it consistently overruns by on the 100 line, which means that what we have, our half day lists, are actually potentially overrunning by within an hour or 2 hours almost every single week. And this kind of reflects the reality on the shop floor, which is to say, actually, what we have here are two ways of operating where we have the same anesthetists, the same surgeons, and the same team, but doing it in different ways. And what we have here is on one element on the full day list, actually things finishing on time and actually operating in the manner that they should be. And on the other side of the equation, actually what we have here are people operating and actually overrunning quite substantially. Now, there's always a conversation here to have with the team and the wider team, more than just the clinicians, with the managers and the various planners to say, actually, is that necessarily a bad thing if we're operating more? Now, the question here is if we use things like efficiency, what we now get to see is our ability to operate in our allocated time, the scheduled operations in the allocated time. And what you see now is the full day list moving above the half day list. So even though the full day list is highly utilized, so they actually use the operating time they have, they're actually also more efficient than the half day list. And again, this drove a lot of conversations to say, how can we improve our care here at site? Now, I'll flip us back onto our actual presentation in itself. So let me just share my screen again, if it works. Fantastic. So amongst the many other sort of flicks of data that I could go through, but probably will not bore everyone about, was a recognition of patients getting sicker that Alistair had mentioned. There was, and in this graph, we have a series of different things from healthy patients in light blue dropping over time, and the ones in orange being the slightly sicker groups of patients creeping up over time. And if you look at a comparison of patients in this period, so 2016-17, to the periods in this period, which is 21-22, what you now have is actually there's about a 10% increase in proportions of patients which were sicker than they were back then. And all of this really drove the point home that there were a series of key opportunities that we can try to recognize here at site. And this goes from late cancellations, increasing complexity. How do we get the estates to recognize that if we were to get our estates and processes correct before, during, and after an operation, what is the opportunity cost here? And this was suggested to increase a whole series of things like length of stay reduction or increase potentially operating time as well. Again, all of this has to be read in context, but the key here is that if we were able to address these opportunities, the productivity gain here was potentially about 12%. And we could do a whole series of different things, from reducing the late cancellations, optimizing the use of existing capacity, and actually the part that it always comes back to, can we improve our patient care at the end of this journey? That was a case study for QEH. Alice, is there anything you would like to add for this part?
The only thing I'd add into that is about returning the kind of joy of work to the staff. Not about none of this for me. And I know for you, Ken, has been about making people work harder. But if we can give people joy in their work, so a lot of increasing efficiency is actually doing things that enable people to have pride in their work, to not be hanging around wasting time whilst waiting for patients to arrive, for example. They want to be working and take great pride in that. So this project for me is about making sure the teams are really happy in what they do and allowing them to get on with what they're experts in.
Thanks, Alistair. We'll come back to this again in a second, actually, because actually what we'll do very briefly is talk a bit about our next hospital, which was ESHT. Joe, do you want to have a quick brief introduction of what ESHT was as a site, as a hospital, or shall I?
That's fine, thank you. Yeah, okay. So ESHT, East Sussex Healthcare Trust. Again, it's quite geographically challenged. It's obviously on the south coast and spread as an organisation in a linear way across that south coast, with two main hospital sites, one in Eastbourne and one in Hastings. There's also provision at Bexhill-on-Sea, and further inland we have other services, community services we support with day surgery on another site. So it's quite widespread, and deprivation is probably a lot worse than I had anticipated before I joined the trust, having not worked in this health economy before. I thought Eastbourne and the South Coast would be quite affluent, and clearly the information that Clear have provided is not the case. So there's a real range of patients that we're trying to manage. The elderly population, as you'd expect, is there. So all the associated comorbidities we see. And so the population is very much specific. People want to stay and utilise their own hospital and have services provided local to their service. So in terms of the population, quite widespread and quite specific, I suppose, to this part of the world.
Thanks, Joe.
Do you want to move on?
Yeah, I'll move on. And this was about a waiting list. If you want to talk a little bit about elective recovery, but I'm very happy to jump in if you like.
So like most organisations, and you've heard already from Alistair in terms of King's Lynn position, the trust was no different to most sites. Prior to COVID, very well high-performing organisation, so didn't have issues as some places in the country with wait times, managed 18 weeks relatively well, and obviously this is evidenced by what is being presented. And this was across the board. So it was during that COVID time and since that the trust has become in a position that they're facing along with everybody else of having backlogs and trying to manage that with tired staff and with all the associated problems that COVID has brought for all of us. So going from a really well-led, well-delivering organisation to one that's not delivering as well for the team isn't an easy position to be in. And obviously they wanted to know themselves what they could do to get themselves back to that high-performing status. Productivity has gone down, and we'll talk about that in a few minutes. Again, similar issues to most other places. And the team at the trust, certainly as I described, I've not been there that long, very open to change. They want to engage in whatever it is we need to do to improve our services and make a difference to patients. But another organisation which is particularly data immature, we have a number of old systems, patient administration system, about 30 years old, and we're on a journey to an electronic patient record, which is going to be another couple of years down the line. So one of the problems we have is, again, getting data, getting it in the right place at the right time, and making sure that the data is accurate, because we still have quite a lot of paper systems and paper information which we have to try and manage. So that in itself, again, another challenge. And so in terms of understanding what the position is, I think, like we've heard already at King's Lynn, knowing where those areas of focus need to be and those opportunities is really important to be able to get that information from our data to be able to then put in place those strategies to reverse that position is really important too. So Ken, do you want to just talk a little bit more about the data side and your involvement in that?
Yeah, thank you very much, Joe, and thanks for highlighting that actually, because I think there were a couple of things about ESHT which was particularly unique and interesting. ESHT, as Joe had mentioned, was actually what identified one of the hospital sites throughout the country to be supported from a national standpoint in terms of new technology, and was trying to understand how the new technology at site here in the form of a care coordinated solution was going to potentially support and assist all of this. And there was a recognition of actually, as Joe had quite rightly pointed out, was that how and where are the challenges at site, and how do we recognize national challenges that we see across the board, and how are they relevant locally, and how do we fix that at a very specific level here at ESHT. Now, at ESHT, we went on to look at a whole series of different things, and like QEH, we sought to understand the key issues across the different areas in hospital. And I'll talk a bit about the key opportunities all throughout, but one of the many key things that we found here were that actually trauma and orthopedics. Actually, let me rephrase that. At QEH, our elective bed base constituted only about 5% of the hospital bed base, which is fairly small. The challenge with having such a small bed base is that there are certain specialities, and trauma and orthopedics being one of them, which require clean beds and clean bays before they can do any operations, become quite severely impacted when they can't move their patients out. And what we have here in TNO data is two sets of information. So one in 2018 and one in 2018-19, one in 21-22. And what we have here are old patients, so 1,479, and less patients in the second cohort in the subsequent points. The next part here that's quite interesting is the parts in red are those patients which are emergency operations, whereas the parts in orange are the parts which are elective. And what you can see quite quickly is that there are a lot more emergency patients operated in our latter cohort than there were pre-COVID. And the third part, which is quite interesting, is that actually, even though we were operating on less patients in 21-22, there were a bigger group of patients that were staying more than 5 days, up to the tune of about 1,500 more bed days. And this meant that in order to account for this additional length of stay, the trust had to now provide for additional 4 beds per year. And that cost the trust, if we were to group it at about £400 per bed day, that's about £600,000 a year to care essentially for the same group of patients that we did before, and actually even operate on less than we could do, and subsequently impact everything moving forward. Because if we can't get our emergency patients back into the community back to their normal lives again, we can't bring our elective patients back in to be operated on. So it becomes a bit of a self-perpetuating-ish challenge. And what we had here at ASH was a whole series of key opportunities. And the 4 areas that they had identified here was systems and processes. So how do we recognize both the elements within this? And Joe had very, very kindly pointed out that ASH actually booking a patient's, whilst fantastically documented and described, spanned about 3 different IT systems, was written on the guidelines that went on for a few pages, and it was very helpful, but actually also reflects the complexity of this booking process. The second part was hospital capacity and patient flow, and that's very akin to what I just talked about. How do we make sure that once we operate on patients, we can move them back into the community so that we can free those beds up so that we can get patients in? Third part, very similar to the ones that we've seen in QEH, complexity of patients have been increasing, and this has been recognized in the clinical workforce for a while, but trying to document it, show it, quantify it. And in this case at ASH, what we had shown was that 20% of patients was taking 20% longer to operate and recover than we did pre-COVID. And how do we now take into account this information, and how do we plan this into the scenario? And then the last part, which is of no surprise to anyone in the NHS, recruitment and retention is a real challenge. And how do we talk about this at a system level? And if we were able to address these 4 key opportunities, the projected impact here is a 10% productivity gain. We reduce the length of stay through a whole series of interventions, but amongst the many things here was a 7-day physiotherapy service, which we haven't had the opportunity to fully describe in more detail yet. Other things, getting the technology to work alongside people to make sure we can get this through, so that we can optimize technology use alongside humans, because actually, whilst technology is fantastic, how do we make technology work best in a population that may not necessarily have the most accessible access to internet or mobile phones and things like that? And last but not least, how do we bring those new opportunities and ways of working and actually built in the workforce solutions along that? And one of the key things that we've found here was a bit about elective care coordinator role that has been described at QEH as well. If anything, QEH was leading the charge on part of these conversations, and actually this same concept being brought out here to ASH allowed this conversation to say, how do we get key people to understand patient complexities, understand patient journeys, understand hospital management needs and planning, and bring those strands together and make sure that the patient getting booked in for an operation to the day which they turn up for an operation receive all the things that they need to get, including optimization, getting allocated the right services, reviewed at the appropriate time, and everything else. Again, I drive back the point. Ultimately, at the end of this, we hope through these opportunities and new ways of working, we improve patient care. Joe, is there anything that you want to add from all of that, which I just mentioned?
I think you've picked up the most important parts of this. I think the period where you came into the organisation was the same time as we were doing the developmental work with the care coordination system nationally, and that's still ongoing. It finishes formally as a developmental project at the end of this financial year, so the end of March. But clearly, what the clear work has done is identified the importance, as it says here, of the new technology, of bringing systems together to be able to make the improvements required in terms of the management of the admitted patient pathway. So it certainly allowed I suppose the way to use that system internally to be focused in the right places going forward. So as we develop it further and we transition into a business as usual model with the technology, then we're focusing in those areas where it can give us the biggest benefit. And I think that's really important. So I think doing the two pieces of work hand in hand through that developmental phase last year has created further improvement and opportunity that we wouldn't otherwise have seen. So I think that's very much the benefit. I think the workforce opportunities we are now pursuing as well. I think that's important. So just to demonstrate that once this is recognised and the evidence is clear, then the organisation then can focus in the right way, and those posts are currently in the process of being recruited too. So again, good opportunities identified. Thank you.
Thank you very much, Joe. Yeah, absolutely. I think it's exciting when we've managed to achieve what we've had to at both sites, and it's been a great journey working on both sides. And I think from a clear end of view, we've been it's been a pleasure working on both ends. I'll stop there and I'll hand this back to Nimisha. Thank you.
Thanks, Ken, and thank you to our speakers. I think that was a really interesting discussion on work with the CLEAR programme. Please do put your questions in the chat or raise your hand if you do have a question. I think one of the things that, I mean, we have touched on this in the session, but I think it'd be interesting to hear a little bit more about next steps at both sites, and perhaps a little bit more about how optimistic you are for the future. You know, there's obviously a lot going on at both organisations, so I think it'd be interesting to hear, you know, if you are able to tell us what your next steps are in your elective recovery plans, and yeah, as I say, how positive you are that or how optimistic you are about you know, being in a different place in a year or two time. Alistair, if we can start with you on that, please.
Yeah, sure. Thank you. Even the term elective recovery is I think is somewhat unfair on the trust, because it's the theatres have already recovered after COVID, after lockdowns released. Theatres were back able to do most of what they do. So clearing the backlog of operations is a little bit different from the recovery. And so I think just in terms of perception, I think it's important to let theatres and the teams know that you know, you're not broken. You're doing a great job. We need to know how we can do more, and that's very difficult. And from an exec level, it's about the target. It's about reducing the 72 weekers and the 56 weekers and so on. But that's very different from the sort of targets that the theatre teams have. The theatre teams generally, they're very patient focused. They're not so worried about the targets. Actually, there's very little they can do to influence those targets. So our focus as a sort of theatre improvement group is not about reducing targets. It's about making our theatres better. And the clear work has allowed us to have a louder voice when we say to our budget holders that, you know what, we need an estate that lends itself well to a great patient experience, to great flow. Then that's been really helpful. So, for example, pre-COVID, we had a ward next to theatres called our surgical extended recovery unit. That was a place where patients would come in first thing in the morning. They'd be welcomed by the actually recovery nurse who would get them ready for theatre. They'd see the anaesthetist, see the surgeon, and the journey to theatre was just down the corridor. It's a 2-minute walk. That disappeared over COVID, and then as our admission unit was located a 20-minute walk from hospital, that's made communications very difficult between the two sides. So there's a list order change, for example, that causes havoc, and the mere time it takes to get the patient ready into theatre is an issue. When we say to our budget holders, we think we need to reintroduce this surgical extended recovery unit, it needs to be located next to theatres. That's a lot of money we're talking about. That's a big move for the hospital. But if we can demonstrate that using clear data, that, you know what, this is a real problem, the estates is an issue here, you can make the patient's experience better, you can make the theatre workers' experience better by reinstating that CERU, surgical recovery unit, then we think that'd be a good thing. So that's something that the Trust are now committed to reinstating, and that's what we hope by the end of this year we have back in place. So that's one example of the clear work, I hope, improving that patient journey. That's one of the things we've got labelled for the year. We've also, alongside that, we've done some other things. For example, rolled out digital pre-assessment so that we have a greater pool of patients assessed and ready for their operation. So we can tinker with the scheduling, improve the way that we schedule, and hopefully be more productive by improving our scheduling and reducing our late cancellations as a result of that.
Brilliant. Thank you, Alistair. Anything else, Joe, to add as to what your big next steps are?
Yes, thanks. I talked a little bit about the care coordination system, which we're now looking to transition into business as usual. And that is a tool. We already have Theatreman, we have a number of systems, but the benefit of the care coordination system is its overarching system use to bring the rotas of staff, the booking of patients, the way theatres work through a theatre scheduling system into one place. So the opportunity to marry things together, which we didn't have before, or manual spreadsheets as the only option, is now pulled into one tool where that information is easily viewable, accessible. So continuing with the use and the work and the rollout of that system as a management tool, and operationally to use that to be able to produce the information we need and drive those efficiencies effectively in the right way is certainly really important. But the work that Clear did identifies where those areas of focus need to be. So making sure that we pick up the areas that we know are the problems, and a lot of that was around the beginning of the pathway. So we've demonstrated in today's presentation that we're seeing patients who are a lot sicker, we're seeing patients who come in acutely because they've waited so long in an elective waiting list. But the part of the elective or that admitted pathway around pre-assessment and pre-optimisation is absolutely key to be able to make sure that we get the benefits that Clear have identified we could introduce, and that pre-assessment and pre-optimisation for the group of patients that we've looked at with the trauma and orthopaedic, well, the orthopaedic especially patients, is going to be absolute game changer stuff if we get that right. So I think a lot of the work now, we've introduced a theatre modernisation programme to ensure that we pick up all of those learning points and we drive them through, and we've got 3 subgroups to make sure that the work of that is clearly picked up in a workforce subgroup to get the model of modernised model of working in theatres optimised. We're having a second work stream, which has been ongoing for a little while now, looking at the pre-assessment, pre-optimisation opportunities. And obviously that aligns with the national requirements as well in the planning guidance for this next year. So I think we're ahead of the game because we've got the information to support doing some of that work early. And it makes such a difference to the whole pathway. Also aligns us to driving more day surgery rather than inpatient related stays, which again is part of the planning guidance requirements, and for a lot of patients is a distinct opportunity if we can get that pre-optimisation in a better place. And then we're looking at the third, or we've introduced a third work stream very much around productivity and performance. So picking up, as Alistair said, how we manage our theatre time, and the care coordination system gives us that information in a way that we hadn't been able to access it before. So I think the three are very much aligned and overseen by this modernisation programme. The other opportunity we have got as we move forward is we have been identified as one of the sites for introducing an elective hub. So there's plans which have gone through the trust governance and is sat now with NHS England for final sign off to develop an elective hub on the Eastbourne site. So that will be a purpose-built unit for modernising our theatre programme and part of the hospital estate. So new facilities that will obviously be fit for purpose. And Alistair's already described the importance of that as we go forwards with our theatre journey for patient care. So new modern facilities are going to be part of that. We're planning operational policies, processes, the staffing arrangements around it. And rather than do that as a standalone piece of work, we've built that into our modernisation programme. So we're doing it in one place. So a lot of what we're discussing in our weekly meetings is very much around what we can do between now and then and what that looks like when we've got the new facility as well in 18 months' time. So it's quite an exciting time, I think, for theatre improvement, but there's an awful lot we can do before. So what we're trying to do is review our practice to ensure that whatever we can introduce now, or certainly before the new build arrives, we'll do that so we can test models of working, ways of working effectively. We've had the opportunity to reopen what was a day surgery unit, again amended through COVID, similar to we've heard from Lynn. Estate changes had to be made at the time, but the day surgery unit that we've got, a lot smaller and not as well aligned, will give us the opportunity to test some of the theories that we've been able to produce. So I think those are the things which will cause the biggest change in terms of benefit to patients pathway and our ability to then deliver and meet the targets that we've heard about as well. So that's our update.
That's fantastic,
Happy
Jo.
to take
Thank you so
questions.
much.
Pleasure.
Really, really interesting stuff there, and lots of opportunities, you know, that you have coming up. I'd like to go to a few raised hands. Can I bring Claire Brewster in? Claire, what's your question or comment?
Well, I'd just like to say thank you. It was really, really interesting. And I've got a couple of questions for you. The first one is, I really feel your pain around the trauma patients and how you balance between your trauma and your electives coming in. And I was just wondering about your medically fit patients, you know, so your neck of femur patients and your elderly. And have you shared this work with the wider ICB and wider partners around how you can kind of highlight how your beds perhaps might be blocked with your medically fit patients, and whether the capacity is out there in the community to kind of push those and pull your trauma patients in. And the other question was, do you have a trauma coordinator? I know you talked about your elective coordinators, but do you have any trauma coordinators in your nursing workforce?
So I think that was really about my trust, so I'll come in there. The first part of the question is, yes, absolutely. We've very much looked at working with the ICB in terms of how we can encourage the discharge of patients and that support as patients leave the organisation. We're doing that anyway. Like most organisations, we have medically fit patients in our beds, and that's across a whole range of specialties, not just these. So there's quite a lot of work that we are doing at system-wide level. We've also had a relatively recent GERFT visit, which was a system visit. So again, analysing our position against others as a system, not just as an individual trust, has given us some of the data and comparative data. So there are areas, as you'd expect, in the other organisations within our system who do things better than us. We do some things better than them, and that way we should be learning now across systems and working together was very much supported with what was presented and what we discussed in that session. So all those things, I think, help for us to look at where those opportunities are more locally than looking further afield. So there's still lots of opportunity there, lots to do. We have got a trauma coordinator, absolutely. And again, like most other trusts, we have more than one site with an emergency department and associated trauma and other emergency patients to deal with. And again, the complexities of trying to carve out the right capacity in the right place at the right time for those patients, certainly those coming on a trauma pathway rather than through an elective orthopaedic or an elective pathway for any specialty, is always a challenge. And we have that challenge as well as everybody else.
Yeah, I think the A&E challenge as well is so difficult, isn't it, when patients are waiting on trolleys for such a long time. Thank you.
Thank you. I think yeah, just a couple more minutes. So let's take another question. Stu, are you there, Stu? Sorry, I don't have your full name. I only have Stu.
I am.
Hi,
My name is Stu. Hi everyone.
Hi.
This has been great. Thank you. It's really been really interesting and very, very engaging. I've been working in comms and engagement in the NHS on and off for quite some time, and always really keen to find out what people are doing to sort of share all of this great news across their trusts wider with everyone. I think it's fair to say we've had 2 or 3 years of absolute hell. Everyone's tired and exhausted. Not always feeling particularly engaged when another new project comes along, when everyone is trying to do their day job. But I think it's fair to say, given that all of the rubbish that we've been going through, we sometimes lose sight of the fact that actually there's a lot of really good stuff going on in the NHS as well, and we need to focus on that. It's just really asking Alistair and Joe, what have you done in your trusts to engage staff across the wider trust with all of this great work and sort of engage them and get them up to speed on what's going on? Because as I said, sometimes people are so focused on the day job and the pressures and stress of everything, and actually they lose sight of some of the other great stuff that's going on. It's really sort of what have you been doing to share all of this great news with your other colleagues?
You're right that there's been so much happen over the last year or two that a lot of this is lost. I think one of the approaches that we've taken with Ken and the team is to try and involve the whole team, at least the theatre teams and the surgical division, so that we hope that most people are aware of this kind of work anyway. But we're still at an early stage of the project. I think we now have a much better understanding of where we can help improve things, and we're now at the point where we now need to do it. We need to get on and make those improvements. So we haven't put out any comms specifically related to that yet, because I think the changes are just being realised now, and so yeah, nothing to the wider team yet, because it doesn't quite feel the right time to do that, and we don't want to put out comms for the sake of comms. Yeah. But I would say that it comes back to my other comment that theatres aren't broken; they've never been broken, and we do try and let the whole teams know that they have always been doing a great job. Nothing's changed from that point of view. So that is a good news story, but that we haven't put out comms related to that.
So for us, you're absolutely right. We don't shout about our successes enough, and you know, theatres aren't broken and never have been, but we do need to modernise the way of working, and having the evidence that we've got from the work that Claire's done has allowed us to focus in the right areas, I think. We have the opportunity, because we've got the care coordination system and the transition is about to happen, to send communication out and re-emphasize what the system and what the opportunities of the system are. And we're in the process of doing that. So as we transition over the course of the next couple of weeks, we will be doing some more communications a lot more widely and introducing the champions meeting, the network meeting, which are for service users effectively to be able to really drive this change further and faster into the organisation. So quite a lot that's happening to try and engage as many people in this as possible, because it's everybody's business. We've also presented the work that Clear have done with us to our executive directors meeting. So it's gone higher up the organisation. I've talked about it at Trust Board as well. So we have shared it at organisational level, and I think that's really important. So everybody's aware of what is happening, what the opportunities are, and where those areas of focus need to be. But there's an awful lot more we can do. I think the NHS are poor at shouting about our achievements generally. So it's a good point to raise, Stu. So thank you for raising it today.
Thank you.
Thanks, Stu. Thank you, everybody. I think we're out of time. Ken, is there anything else that you wanted to pick up? Any final points to raise?
Not much more beyond the fact that everything that Alice and Joe's mentioned. As much as it's been a joy working with yourselves here, it's been actually a really nice learning opportunity for Clear as a program as well, and we're very much looking forward to doing more exciting stuff with yourselves or others. Yeah. Fantastic.
Well, many thanks to all of our speakers and everyone who attended today. Please remember to sign up for further sessions, and all details of the rest of the Clear Week sessions are on our website. So please do have a look and sign up. And going back to that comms issue, please do share this information with colleagues if you think they'll be interested in joining our up and coming sessions. Our next session this afternoon is a panel discussion on recovery and transformation. It's a really great lineup, and that takes place at 2 o'clock. And at 4 o'clock, we'll be running a session on mental health, really interesting session on new roles and models of care to improve access and free up clinical time. So please do have a look out for more details of those sessions. If you have any questions about Clear and what you've heard today, please do contact the team. And thank you very much for joining us.